Yeah, Sandra was talking to me about, I think we found our number 2. we're like 2 people are watching these. Who are they? Anyway, so it's automatically set. I can't start it or stop it. So I'm going to contact IT to see if I can override that stop. I could also just try to only lecture for 50 minutes is another option. Today will just be 50 minutes, but I'll see if I can figure out why. Yeah, it just sets. Like, it just goes. Yeah, I can't start it or stop it. Well, they set it up that way because during COVID, so many professors didn't want to record their lecture, so they just took it out of there, and they're like, we're going to record it and post it to your page whether you like it or not, which is good. But, so, yeah, it's weird here. Okay, let's get started, everyone. So this next, how many weeks? 5 weeks? 1, 2, 5 next 5 weeks, I think are the hardest part of anatomy. And if you've had anatomy, all of you've had anatomy, don't you think the limbs, I think they're just so hard. So this is going to be tough. I've made it, I want it to be as functional as possible, and so I care a lot more about knowing, I'm going to say someone has weak flexion and you need to know like what nerve could be impinged, what muscle is being affected versus like identifying a muscle on, like a dried up cadaver. I care a lot more about functional part of this. You are going to have your 20 questions of identification, but I'm going to have it in as much of an articulated skeleton as possible, a full leg, like they're going to be a little bit easier to tell what the structures are. So focus more these next 5 weeks on the functional aspect of all of this. Joints, the functional part of it. So this week it's a lot, like there's 9 pages, and that's just for this week. It's going to be a little bit simpler the next, after we get all of the bony landmarks out of the way, where it's going to be a little simpler the next 4 weeks. You won't have nearly as many terms. But I also tried to make it as simple as possible. Like if you've had anatomy before, you'll notice there's a lot of landmarks that I'm not testing you on if you've already looked at it. So for people that didn't take anatomy here, just want to get an idea, how many bony landmarks did you have to learn? Did you learn those at all? Did you do a ton of them? Savannah's saying yes. Did you do BYU anatomy? How about some of the other anatomy places? How many bony landmarks did you learn? A bunch. Okay. So hopefully these are all the biggest ones that you already know that are pretty simple. I think that will make this 9 pages easier. You do need to know that brachial plexus. I'm going to test on that. You need to know. I'm going to show really easy pictures of it, though. I'm not going to show the brachial plexus on a cadaver other than those maybe larger nerves like musculocutaneous. The terminal branches I might show in real life, but the tiny little brachial plexus, know like a nice, like the picture I used, know it there. You don't need to be able to identify it in a bunch of different pictures. Let's see, what else? When you're learning the landmarks today, look at yourself on the landmarks. If you're comfortable with your neighbor, you can look at the landmarks and palpate the landmarks on them. I'm not going to show you just like a disarticulated bone and have you tell. I want you to understand on a human being where these landmarks are and palpate as many of them as you can. Some of them you can't. Most of them, I tried to pick ones that you could palpate. Okay, any questions? Okay, let's get going. Let's just go through this pretty quick. Talk about the skeleton. Okay, so skeleton. So the green, this is your appendicular skeleton. You have an axial skeleton here that's in the middle. We're going to be talking about the appendicular skeleton. That's how you spell that, appendicular skeleton. Consists of 4 bones that form the pectoral girdle. Now this varies from text to text. Some of them include the scapula or the sternum. Some of them, in this picture for example, they consider that to be an axial bone. It varies, it doesn't matter. All you need to know is there's a girdle that's going to attach the limbs to the body. And those are typically the most flexible parts, especially in the upper limb. Depends. The knee is the most flexible part in the lower limb. So upper free limbs, that's what we call the upper appendicular skeleton, superior appendicular skeleton. And then we have, for the lower, we've got 2 bones that form the pelvic girdle. These are going to be your 2 os coxa. So typically with some types of arthritis, it's going to present in the girdles first. So when you have someone that has pain in the shoulders and the hips, you start to be suspicious of certain types of arthritis. So just so you know what those terms are. Okay, lower free limbs, and then the axial skeleton is going to be the central supporting axis of the body. The sternum, the sacrum, and then all of the other bones. So like auditory ossicles, hyoid bone, vertebral column, all that stuff, that's going to be your axial skeleton. Okay, so kind of interesting, the evolution of the forelimb. So we're different than we used to be. When we were our ape ancestors, they had really, really substantial upper limb skeletons. What am I trying to say? Their upper limb skeletons were really different because they would weight bear on their upper limbs. So they were much thicker bones. We'll learn about bone tissue and physiology in a few weeks. It responds to the force that you put on it. If you put a lot of force on it, it's going to be bigger, it's going to be thicker. All these big bumps that we're going to learn about, they're there because muscles are pulling on them. So bones are a really, I'm like, what's wrong? Right. And so it's very different. As we evolved to stand upright, our limbs shortened. We didn't have to use that for support anymore. Our limbs shortened, our fingers shortened substantially, but then we also gained a lot of flexibility. So the pectoral girdle in the apes is really, really secure. They don't often dislocate their shoulders. We sacrifice that stability for mobility. So we can move our shoulder in like 180 degrees in all these different ways, and it's because we've sacrificed stability for that. So it's kind of interesting. Okay, so let's talk about the superior limb. So these are the bones. These are the main bones that are going to make up the superior limb. And like I said, it's really, really flexible. We need to be able to reach and manipulate. And so we have a very weak attachment here in the upper limb. This is why I focus so much more on the brachial plexus than the lumbar plexus. Lumbar plexus is important. You're just not going to see nearly as many injuries involving that plexus as you are the brachial plexus. And even more with this, there's a cervical plexus too, that you're just going to see so much more impingement happening. You're going to see so much more stretching and dislocation and things happening at this shoulder joint, and it's because it's so weakly attached. Okay, so let's start at the top. So the girdle consists of the clavicle. That's this you guys all know what the clavicle is. And the sternum. It's going to support the arm. It's going to connect the superior limb to the axial skeleton. The medial end of the clavicle is going to articulate there. It's not what I'm pointing to, yes, to the sternum. At the sternoclavicular joint. We'll learn joints in another unit, but I will mention a few of them here. And then the lateral end of the clavicle is going to articulate with the scapula at this acromioclavicular joint. That one's one that's, these can get dislocated fairly easily because you can see it's like sticking out there. So everyone, you can't really, if you kind of pull your humerus down, maybe you can palpate that acromion of the scapula. It depends on how much muscle you have up there, but if you can feel, I can feel if I really press down. This is one that commonly gets dislocated or sprained, an AC joint sprain, if someone fell on their shoulder. And so if someone has pain to palpation right there, that indicates that there might be a separation, and there's degrees of separation on that. Okay. And the scapula is really interesting. It articulates with the humerus. So we've got some, I didn't give you a scapula. Okay, I'll have to bring around a scapula. So it's going to articulate with the humerus, and it's got this really shallow, where it's articulated here. This is the glenoid cavity, or the glenoid fossa. I think they say cavity on your bolded term. So it's really shallow. That's where the humerus is articulating right there. So you can see how easily that could pull out. You do have a labrum in there that kind of deepens the articulation. It acts as like a plunger, a toilet plunger. It will kind of suck the humerus into it. But you can see it's pretty flimsy. I'll bring this around. It's pretty flimsy. Okay. So here's our clavicle. We've got the sternal end and the acromial end. Again, I'm not going to show you a disarticulated one, so it's going to be pretty easy to figure out which end is which. As long as you know this is the acromion of the scapula, you'll be able to identify it. So this is going to attach the superior limb. It's going to brace the shoulders posterior, kind of like posterior and laterally without it. So if you fracture, this is the most easily fractured bone. It's easily palpated, also easily fractured. If you fracture it, you're going to have someone that's like this. They're going to be holding like this because you don't have that brace anymore. So it kind of acts as like a crane. Let's see, it kind of acts as a crane. I can't really articulate it here, but it kind of acts as a crane for holding this shoulder onto it. So has anybody fractured their clavicle? Usually like 3 people. Mason, Ryan, did you guys have to have, or Joy, you did too? Did you have to have surgery on it? Good. So yeah, it's most easily fractured because it's just sticking out there. If you fall on an outstretched hand, we'll go up through the chain of things that are most commonly fractured when you fall. But a lot of that force gets transmitted right to that clavicle, so one reason it's easily fractured. You have a lot of muscular attachments though, so when you do fracture, it depends on if you fracture it in like multiple places, all those different muscles can pull it out of alignment. So sometimes they'll try to break to just immobilize your arm and let it heal back together. But a lot of times they might have to go in and do surgery. So nobody here have to have surgery, that's good. It's usually you don't have to have surgery, but sometimes if you do, it's because those muscles will pull it out of alignment. Okay, any questions about clavicle? All right, let's do the scapula. So the scapula, this picture probably just is too big, but I'm going to follow, just to kind of keep us in the idea that we're looking at now a full body, not just these disarticulated bones. I'm going to follow the biceps brachii muscle from its origin all the way down to its insertion. You do not have to learn origins, insertions in the muscles. I care more that you know what they do, but it helps to kind of understand the muscle. So just to kind of like connect this muscle to bony landmarks, we're just going to follow the biceps down. Okay, so this is commonly called the shoulder blade. It means shovel, I think, in Latin, and it kind of looks like the head of a shovel. This is interesting because the only direct attachment it has to the skeleton is through muscles. So it doesn't attach directly to the rib cage. It looks like it does, but it doesn't. There's muscles covering the rib cage here. It's not directly attached, and that's how that adds to a ton of mobility. You can move back and forth. Let's see, I think I have a GIF. I'll come back to that. Chromion, I always think this is like, what's this one right here? It looks like a chrome handle, so this one looks a little bit more like a handle. That's the acromion, that's going to articulate in the scapula. And then the coracoid process right here is going to be the one for the biceps. One of the heads of the biceps originates. Okay, so something interesting. What did I tell you? What did I tell you about a nerve that comes off a brachial plexus that's commonly injured with surgery? Do you remember?
Oh, it's the one on the roof, the long one?
Yeah, so what's that? Anybody know what that nerve's called?
The long one.
Yeah. Nick, do you know what that nerve's called? Okay, who knows what that nerve's called? Long is the first part of it.
Long thoracic.
Oh, you looked! Yes.
I had to look.
Long thoracic nerve. And what parts of the brachial plexus, which roots does it come off of? Without looking. Don't look. Just see what's in your brain. Nothing, obviously.
1 through 8, C1 through 8.
Good guess. Yes. C5, 6, 7. So C5, C6, C7 roots are going to make this long thoracic nerve. It goes right down on top of the rib cage. What muscle does it innervate? Good. Serratus anterior. Good. And so the serratus anterior, okay, we'll do the spinous, scapula, supraspinous fossa. I'll talk about those in a minute. Oh, my GIF isn't there. Dang it. So let me talk about what it does. The serratus anterior, there are these muscles right here. And when they contract, they're going to pull the scapula like this around the rib cage. That's what the serratus anterior is doing. What muscle movement is this? Yeah, somebody said it. Say it louder. Protraction. So this is protraction. So that's going to be when you push. This is a boxer's muscle. Because they're punching. You're protracting your scapula. So if you cut that and you go to push, you have someone just push against the wall, your scapula should protract, right? But if it's cut, it won't. It will just stay there. So that's what this lean scapula looks like. There's no long thoracic nerve functions. Okay. So our landmarks, we've got the spine of the scapula here. Palpate, and we palpate that. That one's pretty easy to palpate on the back. Spine of the scapula. That's just going to divide a supraspinous fossa right on top of the spine. Supraspinous, that's easy. Infraspinous fossa, and then in the front we have this subscapular fossa. Okay, and these are going to say. Look at this and palpate the muscles on the top and the bottom of the scapula. Those are two really important rotator cuff muscles. Supraspinatus muscle, infraspinatus muscle. Really important. So if someone's having a hard time pain on palpation there, a hard time moving those muscles, we'll learn what they do next time. Could be a rotator cuff muscle issue. Yeah?
So there's no nerve innervation on that right side, is what you're saying in this picture. So what would, like, is that injury related then? Mm-hmm. Or would it be like they were born like that? Or
well, probably you could be born like that, but in this case, it's probably going to be the way you're going to get tested on the boards is they're going to say someone had a mastectomy because that's right there. You're going to come in, they remove all this stuff, and they accidentally cut that nerve because it's right on top, which is unusual. Usually nerves are buried in the muscle. But you could have that, you could be born with that. In young male athletes, you see it more in males because they just have larger latissimus dorsi muscles. It can entrap it, it can press it. Nerves do not ever want to be pressed or stretched. They stop working when that happens chronically. So it could be a lot of different things. Okay, any questions about scapula? Okay. All right, so 3 regions. Make sure you know the difference. When I say arm, when I say forearm, you got to know that I'm not, when I say arm, you got to know I'm not talking about the forearm, I'm not talking about the whole arm. So the arm is just from the shoulder to the elbow. We could also call it the brachium. The forearm is the elbow to the wrist. That we could also call that the antebrachium. And then the manus or the hand is going to be the 27 bones, including your carpal bones, your wrist bones, all those things. All right, so let's start at the proximal end. Humerus, a couple of important things about the humerus. You got the head of the humerus. You can actually palpate, kind of, I don't know, if you go up under your armpit, don't do this on your neighbor, but like, I'm always like jamming my finger, I don't know. Apparently, you can palpate the head of the humerus if you stick your thumb high enough on in your armpit. You can't get it from the top though, because it's in this joint, but also it's really covered up with muscles. So. Okay, anatomic neck. A couple of interesting things here. So anatomists and surgeons often don't talk to each other. They don't agree on things, and this is one area they don't agree. So anatomists say that the neck, the anatomical neck of the humerus, is going to be where the head attaches to the body, which makes sense if we're talking about necks. And it's going to be like right there. This is a great picture. I like this picture. Right there. But then surgeons think this should be the neck, and that's because this is the most fractured part of the humerus. Right there. So this is a surgical neck of the humerus. This is the anatomical neck of the humerus. This, of course, is going to be more clinically relevant to you because you're going to be clinicians. That's going to be what you're going to see fractured most often. Okay, so if we're following our biceps down, the tendon of the bicep, this is a short head, the tendon, or that's the long head, the tendon of the long head is going to go, there's a couple different heads, there's 2 heads, that's why we call it the bicep. It's going to go down through this little groove between 2 landmarks. Oh, I don't have one here. So the 2 landmarks is a greater tubercle and a lesser tubercle. Again, these are because there's muscles attached to it that are pulling at it. Got lots of things pulling here. And then the bicep of the tendon of the bicep is going to go down through that little intertubercular groove, but that's not a bolded term for you. Okay, at the very end, we've got these epicondyles. We've got medial and lateral epicondyle. This is going to be where all of our forearm flexors and extensors originate. That's why they're so prominent, why they're kind of pulled out to the side. And then we've got a capitulum and a trochlea. They're down here. This is going to be where our other bones articulate with. And there we go. And they're gonna. The reason they're smooth is because, yeah, all of this joint motion here. Okay, this medial one here. So what's that? What do we call that commonly? Your funny bone, right? I know, the worst. So just orient yourself. What nerve? We haven't talked about this yet, but let's see. What nerve is going to be going here on your thumb side? Your radial nerve. Yeah, your ulnar nerve is going on the pinky side. Associate your radius with your thumb immediately. Like that should just be second nature. So you don't have to be like, okay, anatomical position. This is just automatically associate radius with the thumb. That's going to be lateral. Anyway, so your funny bone is really just that medial epicondyle and the ulnar nerve running over it. And so you just see it's out there. It's got this big bony prominence. There aren't any muscles really there. So you just zap it easily. Did you have a question? Sure. Okay. Okay, any questions about the humerus? That was it, like hardly any landmarks. Way less than you probably had to learn in undergrad, right? Next one, so we're going to go, we'll do radius and ulna. Let's do radius first. Okay, radius, lateral bone. Radius is lateral. The radial artery, radial nerve, radius, it's all going to be on that thumb side. So this is one, it's got the head of the radius is this really rounded point here. And it's going to articulate, can't like really put it together there. This is probably the best way to put it together. It's going to just rotate here. This is how we're able to supinate and pronate our forearm so well, is because this radius has this rounded thing here. It can just twist in that space. Okay, so let's see. We got a little radial tuberosity on the front. I think I unbolded that one for you though. The head of the radius is the rounded part. There's a little ligament, an annular ligament that wraps right around there. It's pretty, there's not a picture of it here, but it's pretty cool little ligament. But that, especially with kids, if you're like grabbing them and dragging them along, can pop right out easily. But I don't know, because I swing my kids like full force, like just their hands, like full, and it hasn't popped out yet. But I'm always like, is that going to pop out? Okay, so if we're following our bicep muscle, it's going to go all the way down the humerus and attach here at this radial tuberosity. So it crosses all of those joints, but really it's just flexing. So that way it's useful to learn the attachments because I know now that the action of the bicep is to flex the elbow because it attaches there. If it attached to the humerus and it flexed, it wouldn't do anything, right? It has to attach to the bone to be able to pull it up. So it's helpful to go over those origins and attachments but maybe not commit them to memory if you don't already know them. What? Yeah, nursemaid's elbow, because the nursemaid was grabbing the kids. I don't know if that's a great term, but that is what that is. Yeah.
My daughter literally had that this weekend.
This weekend? What happened? Yeah.
My wife was holding my daughter's arm and they just walking down the stairs and my daughter just decides to jump.
Oh. Yeah.
And totally, yeah, she jumped. And so I pulled out and I have a sister-in-law who plays the ER doc. And so my wife, I wasn't even home, my wife called her and she had her just put it back in.
Oh, she just put it back
She
in?
told her how to do it. And she
Oh my
did it
gosh.
at home.
Awesome, and it's fine?
Yeah.
Oh,
I've done it for myself.
you have? I have not.
YouTube videos for it or
Oh,
not?
no.
Oh,
no.
Yikes.
I'm not good at that stuff because I cannot, like, when I did, oh, no.
It's great.
When I did my surgery rotation, I had to walk by the surgery. I'm not kidding, I had to go like that. Because their knees were like up and open and they were like, I cannot, they are. They were like full.
Hammers and like.
Oh, yeah.
A fun fact and something to remember, our biomechanics professor here, he always said, if you want to swing your kids around, grab them by the feet. Because it's a lot
You can hit their
stronger,
head.
And there's some biomechanical advantage where we can actually spin them faster.
Oh my gosh. I'd rather dislocate my kids' elbows than hit their head against. I mean, I should just stop spinning my kids.
The kids love it.
They do. You know what I do? I do their hand and their leg, so they're like super.
Oh, yeah,
That's what I
fine.
do.
Or you can do it like under here.
Oh yeah, that's true.
I used to do that with my daughter.
That's true. That's a good one. Yeah. Okay. Bad advice to get in anatomy. Okay. Any other cool tidbits about the radius? Oh yes, Drew has another cool tidbit.
So I put it in the group chat. I have a picture on my iPad, a little picture of my X-ray. I snapped my radius completely in half.
Oh wow, where? The distal
I-
end or the middle? Or?
Yeah, so the distal end and then the whole nose cracked as well.
Wow, fall?
Yeah, I was diving for, that's really cracked. I was diving for baseball.
Oh.
Classic,
So you
yeah.
put your hands out like Superman,
Yeah.
catch it. So
Oh, you fell like that?
I went out like this, and when I landed, it crushed it.
Ooh.
Catch it. I did catch it.
Oh, good job.
But when they had to reset it, they had to reset it prior to surgery first to get it to more like a normal arm. So
Yeah.
the ER doc, once they had me like, oh, go get one more, she put his arm under, my arm under his leg like this and
Ooh.
kind of like turn around and
Nope.
this boot gang.
Nope, nope, nope.
Never did that.
That's terrible. So that's the biggest part. If you're ever tempted to reset something and you're out there, out in the field, I mean like the
Like the
working
baseball
field, yeah, baseball, wherever that field might be. If they're feeling like you can do that as long as they're like if it's painful, you need to go to the ER. If you can reset that and it's not painful, it's fine. But like if they're in a lot of pain, you go to the ER. Don't try to do it yourself. You'll probably learn more about that with your clinical medicine. Okay, and then the ulna is going to be the medial bone. It's pretty small. I mean, it's actually not very small, but the top of it, the head is actually at the bottom, but the top of it is pretty beefy because that's going to be, the major part of our elbow joint where we're doing this hinge. But the rest of it is actually kind of flimsy, and it doesn't really take a lot of bear a lot of the force. And so we have this interosseous membrane. So when you have a fall on an outstretched hand, we call that a foosh, F-O-O-S-H. Fall on an outstretched hand, yeah. It sounded stupid when I first heard it, now it's like, oh, a foosh. Dumb, I don't know. But when you have it, when you fall on the outstretched hand, that radius is going to be what articulates with your carpal bones, your wrist bones. So that's what takes all of the force. And so we developed this interosseous membrane really meant to transmit some of that force onto the ulna. So by itself, the ulna, you can see it doesn't really articulate with our wrist in any meaningful way. And so whereas the radius really does, this is going to be what's going to articulate with our wrist. So that's going to take all the force. So this interosseous membrane is just going to try to put some of that force onto the ulna, so that so it doesn't have to take all of it. So obviously that's probably why you broke your ulna too, is because that force got transmitted over to it. So that's a big, yeah, you fooshed it. You fooshed the crap out of it. So this is not something, oh wait, let's see. Did we have, no, we didn't. We already talked about our biceps. So this is not something that I'm going to test you on. And I'm only briefly going to mention it because I think you're probably going to talk a lot about it in your other classes. But we do have these different kinds of, here's our foosh, different kinds of fractures. There's a Colles fracture when you fall on an extended hand. There's the one that Drew probably had, a Smith fracture, where you fall on a flexed wrist. And this is going to be the most common way that you fracture that radius is through the distal end. Okay, any questions about the radius or the ulna?
Is that in through one of the...
It's through the styloid process. This is the radius. Yeah, it's through that styloid process of the radius. All right. Okay. So carpal bones. Okay, so first talk to for someone next to you. Identify your carpal bones. Where are they? Palpate them wherever you think they are, and try to figure out what's the proximal row, what's the distal row. So go ahead and spend a second doing that and talk about it.
Scaphoid jump is of course. I don't know if that's my radius or that's...
Yeah, figure out where your radius is, where your ulna is. Just orient yourself.
Oh yeah, I know, like that could just be...
Drew, do you still have, like, can you feel where you broke it still? Is there like a bump? Oh yeah, I can see. Oh wow.
I just sang a song. What is it? Sing to us. You ready? Yeah. I think I would start on this side. It would say, easy up, trapezoid, and you just go.
Oh yeah, that's cool. And a whole scar.
Yeah, like compared to it, looking this way is completely funky. Yeah. So the pin I had gave me tennis elbow, because I was playing baseball at the same time. So they took out the pin. I think all that just kind of messed with the way it grew. So it definitely looks a little funky still, but
Yeah. Is it still pretty functional though?
oh yeah, totally. Yeah. The PT was the worst, honestly.
Like in what way? Like it hurt the worst, or it was the worst in?
Yeah, and honestly, it hurt more than breaking it. Because he had to massage the scar tissue, and then he would lay his head on my hand like this to get it to, because I could go like this with the other hand, but I could only go about that far when I first broke it. So he said, like, when you sleep on it, it'll be okay, because you'll usually sleep like this or like this. But when I was awake, I had to practice that and keep it, not fun. But luckily, my grandpa's best man was top ortho in California.
Oh, great.
Yeah,
That's so great.
He got me right in. So
Those connections are great. I love it. Okay, so where palpate your carpal bones. Show me where you palpate. Good. I kind of thought, like before I took anatomy, I thought they were down here in the wrist. They're up in the palm of the hand, in case you're. So they're all up in the palm. And then which row is proximal here and which one's distal? So what color? Oh, it says.
Because it's proximal to us.
Right. So just orient yourself. I'll try to show you. I'll show you a hand that has a radius and ulna attached. But yeah, make sure you're oriented, because you do need to know. You do need to know some sort of mnemonic, I think. And there's a BYU version. Who went to BYU and has a mnemonic for this? There's a BYU version and there's a UVU version. Okay, Sandra, what's your BYU version of this?
They told us so long to pinky, here comes the thumb.
Nick's like, what a BYU mnemonic. Good, that's a great one. There's a bunch of them. And then the UVU one is some lovers try positions that they can't handle. So either one, you're at UVU now. Feel if the BYU one vibes with you more, take it. If the UVU one vibes with you more, take it. But learn a mnemonic. Tell us again, Sam. That they can't handle. Okay, Sandra, tell us yours again.
So long to pinky.
So
Here
long.
comes the thumb.
So long to pinky, here comes the thumb. That one's great. And it's a hand. It's a hand theme. That one might be more helpful. But either way, learn a mnemonic and know you're starting from proximal and going. Let's see, where are you going? Laterally? Yeah. So we're starting proximally, we're going laterally with that mnemonic. Good. Okay. Any questions about that? So, kind of interesting. They're not fully formed in kids. We'll learn there's several bones that aren't fully formed in kids, and so and some of them aren't fully fused either in kids. So kids have more. They actually have what? Oh,
It's so weird.
Yeah.
I was talking about Nick, I was like,
Yeah.
I'm missing like 5 carpals.
I know. And also like with growth plates, you gotta like recognize, you gotta realize you're looking for growth plates too. It's not a fracture. And so this is an adult hand, but then this is a 2-year-old, so you can see like. You can see like these are not even, there's like tiny, look at those tiny
How's their
little
thumb
carpals.
attached?
This is kind of how this is too, like I've had my kids like take these huge falls and it's like, how did you not break everything in your body? This is part of the reason a lot of their bones are still mostly cartilage.
Where's their scaphoid?
Yeah, it's not even like, it's not even, it's a
from?
tiny little dot. So here's the radius. So yeah, this is going to be, they're going to form throughout life. And then an 11-year-old, they're still not fully formed. So that's part of the reason they're pretty flexible. You can see some growth plates in there too. What are sesamoid bones? They're what?
Like the weird
They're
square
embedded
shape.
in the tendon.
Yes, we also, they are all a specific shape. Say that, I like that one.
Like all weird squares.
What'd you say? Was that you, Scott? About
Yeah,
the tendon?
embedded in the tendon.
Yeah, a lot of them are embedded in the tendon. So yeah, they are up. The reason we call them sesamoid bones is because they're this shape that Brittany was saying that looks like a sesame seed. So they're smallish, and they form throughout life depending on how much stress we put on certain joints. And so there's typically they're the base of your thumb, the base of your big toe, because we're moving that a whole lot. They form inside the tendons. The patella is a sesamoid bone. It's the largest sesamoid bone. There's my patella. But they're another one that they don't form until a little bit later. And you could form extra ones if you're like a gymnast or a dancer, or someone that's using those joints a whole lot. Maybe climbers too. Now that kids are climbing younger and younger, they'll form extra ones. You can also break a sesamoid bone. Here they are. This is that shape that he was talking about, the sesamoid shape at the base of the thumb. So you can actually fracture those, and they can cause a lot of problems too. Okay, oops, my picture's all resized here, but a couple other, really important carpal fracture that you need to know. Does anyone know what the most commonly fractured carpal bone is? Scaphoid bone, and that's because that foosh, fall on the outstretched hand, that's going to be the one that takes the first impact. It takes that impact, it goes up to the radius, but that scaphoid bone is going to be really commonly fractured. So locate that. Here we go. It's right at the base of the radius thumb, remember. That's your scaphoid bone right here. This is an important one because there's not a great blood supply here. We want to identify when this is fractured. And we want to get someone to the hospital ASAP. Regardless of what an x-ray shows, sometimes we just assume it's a fracture because sometimes, a lot of times this fracture won't show up on an x-ray until it's been 10 to 14 days and the bone actually starts to dissolve away and then we can see it on x-ray. So what we look for is we palpate here. If there's pain on palpation, a lot of times it will dip. You'll see this little extra dip hill here. You can palpate right in there is another place you can palpate to get pain here or here if this is dipped down like that.
Doesn't that have a special name on the physical exam that you
Ooh,
call
maybe.
it?
I don't know.
I
Does
can't
anybody know?
remember what it was, but I think it
This
does
is the
have-
anatomic snuff box?
Yes. Snuff
Oh,
box.
okay. That's what you're talking
Yeah,
about?
the snuff box, like snuff box fracture.
Yeah, okay, yeah. So this is your snuff box here. So if you see like an extra, I think that's your snuff box. Maybe it is that. But this is your anatomic snuff box, so everybody can do that because you can snuff cocaine out of that little. If you didn't have a line that you wanted to do, you could just put it right in there and snuff it out.
You seem really good at that. Is there something you want to tell us?
I've been through medical school. Cocaine for the days, Ambien for the night. No, I'm not done cocaine. I should probably not ever do cocaine so that I can continue to say that. I'm just thinking. Okay. So anyway, yeah. So if you have tenderness there, that's a good thing. Okay, so that's a really common. And if you're not sure too, like friends will ask you too all the time. Now that you're medical, maybe you've already had that happening where everyone is going to ask you all the medical advice. If they're, because fingers, it's like, you know, you can't really cast a finger. People don't go in for finger fractures. But if it's here, then they need to go in. It's an emergency because you don't want to lose. If you lose your ability to articulate your thumb, that can be really devastating, especially for someone that works with their hands in any way. Another one, it's less common, but just kind of interesting. So we've got the hamate bone here on the lateral side, and we've got a little hook of the hamate bone. I think that's on the other side. No, it's right here. So the little hook of the hamate bone, it's not bolted, but it's a little hook that comes around and the ulnar nerve passes through it. In people that do like batting or golfing, I mean, you shouldn't, I don't think, hey, Drew, you're a batter. Would pressure go right there when you're hitting?
If you hit it
Just
like
all over?
If you hit it on the handle, yeah, you definitely get ringing all out.
Oh, okay.
It hurts really bad.
Okay, cool. So I guess, yeah, baseball, but also golfers. If you have a huge force hitting there, you could break that little hamate, and because the ulnar nerve is there, it would be important. So also palpating there to determine if someone has a serious injury that needs to get evaluated. And like I said, a lot of times we don't even rely on x-rays. We'll just go in and, I don't know how you fix a scaphoid bone, but, oh, you do? Deborah. How did he do it? Oh, dirt bike. Oh, man, that one. They pinned it. If you could imagine, because again, like there's not great blood supply there. Anytime you have really good blood supply to a bone, it heals fast. But if you don't, then it just takes forever. Yeah. Okay. Thanks. All right, and then metacarpals and phalanges. So I think the important thing to know here, we're just getting more. So as we go down, we get more and more. I'm not sure if this is the most mobile. We get more and more different segments of bones because we get a lot of movement and a lot of joints because it helps us articulate here. I think something important to know from this slide is where they are in your hand. So what bones are here? Yeah, your metacarpals are here. The head of the metacarpal bone is going to form your knuckles. So common injuries here are going to be this fifth one. So they call it a boxer's fracture, but I don't like that term because boxers know how to punch. This is more like Friday night bar fracture, or like anger management fracture, which is why I chose the picture. Yeah, the picture of an idiot Will Smith fracture, we will call it. Yeah. Idiot fracture, unacceptable.
It was more like an open face.
Yeah, it's true. But still, the idiot Will Smith drunk fracture. I don't know, whatever. So that's why I chose the punching a wall because it's more like it's like a non-trained fracture where all the force is going to this fifth metacarpal bone. So make sure you know how to number the bones as well in the hand. So this is digit 1, 2, 3, 4, 5. This is metacarpal 1, 2, 3, 4, 5. Make sure you know how to number. But this one's probably the most commonly fractured. It's the littlest, right? And a lot of times, so someone coming in that got in a fight Friday night or whatever, or was angry and punched a wall, and they have pain on that metacarpal here that probably fractured it. Okay, just looking at x-ray, where would a ring go? Think about where a ring would go, or wedding ring. I think this is not even a left hand, so I shouldn't have said wedding ring. We'll just think yes, but think about where in the x-ray it would appear. So just think about it in your mind. Create a picture. Right there! So just make sure you know what you're looking at. I think, again, I would have probably said there before he took anatomy. So make sure you know these aren't just like really long fingers. Okay, so when you're just orienting yourself on x-ray, of course. Any questions about superior limb? All right, let's look at inferior limb. So similar kind of theme. We're going to be most flexible, the proximal, the hip joint, less, I don't know, that's not really quite the theme. It's not totally accurate, but a lot of mobility in that hip joint, less mobility in the knee joint, and less in the ankle. So as we're going to see injuries as we go down. This isn't totally, like the most common place to injure depends on your age. If you're young, it's going to be the knee, probably because you're in sports. If you're older, it's going to be the hip, just because that had the most mobility and it wore out as you aged. So hip is going to be most mobile because it's a ball and socket joint, so you're going to be able to move that hip in all these different directions. Not nearly as mobile as the shoulder, right? You can totally move your shoulder all these different ways. It's a little bit harder to do that with the hip, and that's because that girdle is a lot more substantial. The stuff's in there more securely, as we see. The knee, we'll talk about the knee a little bit next time. It can move, it can hinge back and forth, it can extend, it can flex, and then there's a little bit of rotation that it can do. And then the ankle shouldn't move a lot, but we'll see that even like rolling it a little bit in the wrong way can sprain it pretty easily. It should be pretty stable. Okay, pelvic girdle. So this is a total ring, so already very different than the pectoral girdle, right? It's a totally enclosed full ring. You've got the sacrum at the back, you've got these hip bones on the side, and they're fused together with a pretty immobile joint in the middle. Now you can, usually those aren't dislocated. If you're pregnant though, these get really flexible. I dislocated this joint when I was, or like this got really, really soft because all those hormones make these really soft so it can expand, right? I didn't carry my babies out, I carried them down in my pelvis, and my pelvis like totally came apart. And I heard that started to come apart, so like I put all my weight back and then I dislocated that. So like these shouldn't dislocate, and you always learn like these are really stable and they won't dislocate, but I dislocated both of them. So I think in pregnant women too, I think that's gonna be one case in which these will be a lot more flexible. Okay, so that's what it looks like with all the ligaments in there. So not only do you have this bony circle, which should be pretty stable, but you have tons and tons of ligaments reinforcing it. So this is a pretty stable structure, typically. When we talk about the pelvis, we're talking about, when you just hear that term in medicine, this is, when we say the pelvis, we're talking about all of the stuff in there. So all of those muscles, you have this pelvic bowl at the bottom of an intact pelvis. We've got this like whole bowl in here of muscles that should keep everything in there nice and supported, the bladder, the uterus, things like that. But those again can be weakened, especially in pregnancy. And we're also talking about the organs in there. So when we say pelvis, we mean everything.
What do they do for your dislocation?
Nothing. It's still if I move wrong, it will pop out. I should have gone to a physical therapist. I don't know. Does anybody know what they do for an SI joint? I don't know. It seems like if I like move in the right way, I can kind of pop it in sometimes, but it usually will stay out for 3 or 4 days. It was very, very painful, that one was. Okay, sacroiliac joint, that's the one I was talking about here. And then the pubic symphysis, that's that one here. All right, let's look at the os coxa. So the os coxa, I don't have one, you have one on your tables there. In the adult, this is fused. But these 3 bones don't actually fuse until about the age of 21. So I don't know what the purpose of that is, but they're actually 3 fairly separate bones. They're still intact, but there's like a little cartilage joint between the 3 of them. So that's why we name them separately. So this is the ilium here. And the big landmark for that is your iliac crest. So see if you can palpate. It's like on your back here. I should use the skeleton. So you can palpate that. Goes around the front. That's a big one. That's an important landmark. We'll use that for intramuscular injections. I'll show you in a minute. What's this little one in the front called? What's this part of the bone called? That's the pubis. That's going to come around to your pubic symphysis. What's this one called under here? The ischium, yeah. And this big one here, the ischiatic tuber, is the big landmark on this one. These are covered with gluteal muscles as you're standing up, but when you go to sit down, gluteal muscles kind of go out of the way, and this is what you sit on. Savannah's like, yes, I know what you're talking about. So wobble around in your chair, and you can kind of feel your sits bones, they call them sometimes. That's your ischiatic tuber. When you're standing up, you can't palpate it, but I don't know why you need to palpate this. Don't palpate it on your neighbor. But like, you can feel it when you're in that flex squat or sitting position. Another thing, so greater sciatic notch. These aren't bolded terms for you, but you have this big notch in the ilium. That's going to be where your sciatic nerves comes out of. Ischiatic tuber, that's this one, your sit bone. Pubis is going to curve around medially. Okay, any question about that one? Okay. When you break a hip, what are you breaking?
Typically the femur.
Yeah, weird. I don't know why we call it that. When someone says they have a broken hip, it's usually the femur bone. When you have a broken pelvis, it's your os coxa. So I do not know why we call it that. The important one here is going to be the acetabulum of the os coxa. And that's just like the glenoid cavity. But you can see it's already way deeper, right? So you can see a huge difference in the structure of this joint. It's way deeper. You also have a labrum in there, so it's going to be like a toilet plunger. It's going to suction that hip or the femur bone in there, but much more stable. You totally can dislocate your hip. Has anybody done that? Your femur from your, but it's way harder than you do. Usually it's like a car crash or something. Okay, so one landmark we use that I don't know, do PAs do? I mean, nurses for sure are going to do intramuscular injections. We never learned in medical school, we never learned to do injections. They're like, oh, the nurse will do that, which was unfortunate. So I don't know, I'm kind of thinking it's the same thing with PAs. That you probably won't need.
Depends on the scope of the doctor that you're working on.
Yeah.
I've seen some do it and some don't.
Okay.
Yeah, same.
So this, yeah.
I used to do these a lot as an MA, but.
Right, MAs, nurses, they usually don't have the PAs or MDs do these. But in case you get, I mean, it'd be cool practice. In case you do that, you put your palm over, we didn't do the greater trochanter yet, that's on the femur bones. So you put your palm over.
Oh my gosh.
I feel like a magician. So, yeah. So this is a greater trochanter. This is huge because it's where our glute muscles attach. So we're constantly extending those glute muscles, pulling at this bone, making these. You put your palm there, and then you put your upper fingers on the iliac crest, and you do an intramuscular injection between the two. And the reason you want to be really specific about where you do it is that there's some areas, there's tons of nerves in certain areas here. There's variable fat in this region, right? Like over here, like there's going to be a huge variation in how much fat is there, how much muscle is there from one person to another. So like you could have this much fat and like you're not going to have a needle long enough to get to the muscle. We want to get to the muscle for an intramuscular injection. So this area, there's a lot less variation. You can kind of just palpate on yourself. There aren't any nerves going through there, so this is a great spot for your intramuscular injections. You can do the thigh too. So intramuscular injections, it's going to absorb a lot slower than if we put a medicine in the vein, but faster than some other sites. Okay, any questions about that? One other thing, sciatica. So the greater sciatic foramen, again, I didn't bold that, but that's going to be where a really important nerve comes out. The sciatic nerve, that's going to innervate all of the backside, all of your hamstring muscles. It's going to divide and innervate the back calf muscles. So really important, a lot of things can go wrong here. A disc can compress it, sciatica. If you worked in a neurology office or a surgical office, they hate that term a lot of the times, sciatica, because it's kind of a catch-all term for a lot of different processes. But anything that's kind of causing irritation to that sciatic nerve is gonna cause pain in the back, radiating down to the back of the leg. It's coming out here. So one muscle, piriformis muscle, it kind of sandwiches, it goes right under there. Can't even ever see what I'm pointing to. It goes right under there. This piriformis muscle, if you're a cyclist, if you're biking a whole lot, you're sitting on that muscle and causing a lot of damage and compressing it. That's called piriformis syndrome. That can be one cause. So just to kind of put all the different structures together. Okay, lower limb. So similar arrangement as the upper limb, but adapted for weight bearing and locomotion. Therefore, the articulation is a little bit different. The thigh, so same thing as the arm. When we say thigh, that means the region from the hip to the knee. We could also call that the femur. Femur bone is talking about the bone. If we say femur, that means the whole thigh region. The leg, so kind of similar to the arm, but this one, if we're going to say leg, that's just referring to the knee, to the ankle. We can also call that the crus. And then the foot is going to have, we know what the foot is. It's containing the tarsal bones and the metatarsals and phalanges. Okay, femur bone really quick. Longest and strongest bone of the body. Harder to fracture if you're young. Takes usually I think the cases I've seen were like a ski accident or a car accident. But if you're over the age of 55, it's one of the most easily fractured bones, especially in women because of osteoporosis. It sets in there. There's a lot of spongy bone. We'll learn about what that means when we do physiology. Okay, proximal end, you've got the head. That's going to be what articulates in with the thigh, with the os coxa. So you've got the head of the femur bone here. This is going to be obviously a really good ball and socket joint. You can move that leg in a lot of different directions. A lot of muscles though, so it can really limit the movement. Greater and lesser trochanters. Lesser trochanters where your hip flexors articulate. And then the distal end, we've got these condyles that are going to articulate with the tibia. We've got a medial and lateral condyle. So you make this really cool hinge joint on the knee. So they're pretty prominent condyles. and then a patellar surface for the patella. Okay, patella. So this is a sesamoid bone. It's huge. So it's surprising it's a sesamoid bone. It is. It's pretty important. There's some disease where people are born without or they never develop a patella. They have a really hard time extending that, standing up. So that's going to be extension of the hip joint.